In the last class, we discussed about dengue, and in the same breath, usually when we utter dengue, automatically comes the word chikungunya. In this class, we shall take up the chikungunya as well as two more important viruses as regards Indian situation. One is Kayashanur forest disease, and the second one, the emerging viral infection in India, Crimean Congo hemorrhagic fever. Regarding chikungunya as an introduction, I would say that this is a mosquito-borne viral disease characterized by acute onset of fever with severe polyarthralgia as well as skin rash. Usually the rash follows either in the first or in the second day, and this is usually followed by chronic arthritis, which may remain for months together, even years together. This we encounter chikungunya often as a large outbreaks with high attack rates, and outbreaks have been witnessed in different parts of the world in the past. And in India, the outbreaks of chikungunya was devastating in the first decade of this millennium. In 2013, first we noticed that it spread even to the New World, and we find the chikungunya has hit the Caribbean islands also. So, about chikungunya, it is a mosquito-borne disease, and it is a single-stranded RNA. The RNA is a positive sense RNA, and it belongs to the class Arbovirus, family Togaviridae, and genus Alphavirus. It is transmitted by two vectors in our country. One is Aedes aegypti, that is the primary vector, but nowadays Aedes albopictus transmission is more than the Aedes aegypti. And both these vectors are aggressive daytime biters. The name chikungunya is very fascinating. It is derived from the Swahili word meaning that which bends up, referring to the stooped posture of the chikungunya virus patients, and that which is the hallmark of chikungunya virus. I had a chance to investigate cases of unknown fever in North 24 Parganas once. There I find that the patients, even 18 years, 16 years old, robust health youths, they are coming to the clinic, bend up and using a stick to support their body. So such is the grave condition of the arthritis of big joints of the lower limb. So virus is an alpha virus, it's Togavirus family, and it is closely related to similar viruses of other parts of the world. One is Onyong-Nyong, and another is Ross River viruses. So in the diagram you will find the virus, it is a spherical virus, it is an icosahedral structure, it is an enveloped virus, and we find papillomeres jutting out of the envelope. And virus, first, since it is a positive sense RNA virus, it needs to be converted into the negative sense first. But before that, some part of this positive sense RNA virus encodes the non-structural proteins as well as some subgenomic RNAs. This non-structural protein is responsible for conversion of this positive sense RNA into the negative sense one, so that the messenger RNA now can be produced for the production of the viral proteins. In addition, this is also responsible for the replication of the viral RNA for the packaging in the newly developing viruses, so that the new viruses get a copy of the same RNA as well as the proteins material that is required for in its structures, like the inner core protein, like the capsomere proteins, and the glycopeptide peplomers on the surface of the virus. Vectors, I already told that Aedes aegypti and Albopictus. Both of these also transmit the dengue virus. The larvae develops in the peri-domestic area, even in a very small collection of the water. As regard the vector, it is said that there are very aggressive biters and they are nervous biters too, and there are daytime biters. Because of the nervous biters, they cannot complete their full blood meal in a single bite. That's why it repeatedly bites even as different members of the family. That's why we find that dengue and chikungunya occurs more than one members of the family, not in case of like the case of Japanese encephalitis, where Culex is the responsible vector. Regarding Albopictus, it is said that historically chikungunya was transmitted principally by Aedes aegypti mosquito. But in 2006, the virus acquired a single mutations in the E1 proteins that helped it to be adapted onto the Aedes albopictus mosquitoes. And since Albopictus is more prevalent in different geographical regions, nowadays the principal transmitting agent is Albopictus. So we find the two mosquitoes on the upper left area, it is Aegypti, and the lower area, it is Albopictus. And we find the peri-domestic small spores and etc., which can support the growth of these mosquito larvae. Even if the water content may not be very high, even 1 ml water is sufficient for the support of these mosquitoes. Often it is asked the difference between Aegypti and the Albopictus is distribution. Aegypticus predominantly an urban vector, breeds close to the household and can bite indoor and outdoor also. But it is Albopictus, it is a rural vector. Nowadays, dengue and chikungunya are found in the rural area also. This is because of the change in the vectors. From it was earlier Aegypti, now it is mainly Albopictus. It breeds far from the households, mostly in the it is outdoor biter. Global distribution, Aegypticus, narrower global distribution, but wider global distribution we find in case of the Albopictus. Tendency to bite the human, Aegypticus occasional, but Albopictus aggressive. Preferred source of the blood meal, which preferred human in case of Aegypticus, but Albopictus, a variety of vertebrate. Nickname, yellow fever mosquito, Aegypticus, and Asian tiger mosquito, Aedes albopictus. And this is the, this diagram depicts the epidemiology of the virus. We find that the sylvatic cycle is maintained between the vertebrates, especially the monkeys, and the mosquito in the forest. By chance, these forest mosquitoes may venture into the rural adjacent areas and their bite transmit the virus to the human being. And once this is done, the human to human cycle starts, where the mosquito is the responsible vectors. And nowadays, because of the widespread travel by these people, it spreads to the other areas, different urban areas of the world also. So this picture demonstrates the darker areas where the Aegypticus and Albopictus are prevalent. Note that in India, both are found. And this demonstrates the spread of the virus from the African, Central and South African regions to the Indian Ocean islands, and then to Indian subcontinent, Southeast Asia, and subsequently by air travel it is transmitted to the South New World, especially in the Mexico and other southern countries of the North America, as well as in South America also, especially with the Brazil, where chikungunya is quite prevalent. Now, after the bite, this is what is the journey within the body. We find the mosquito bite deposits the virus in the skin, and initially it is in the fibroblasts of the skin where it multiplies. Then it finds its way through the lymphatics to the local lymph nodes, and from the local lymph nodes it multiplies and taken away, and then invades the macrophages, which takes it to the different locations of the human body like liver, the joints, skeletal muscles and the brain. So it depicts the different areas of the human body where the virus ultimately shows its abode or according to its tissue tropism. We find the liver, the spleen, we find the muscles, joints and brain. And chikungunya is characterized by its chronicity of the infection. Initial infection usually subsides in 5 to 7 days, but that leaves behind a robust immune response. And second point is that the elimination of the viral RNA and antigens from the body is not complete usually, and it remains in the secluded locations of the fibrous tissue of the joints. And because of the sustained presence of the viral RNA and antigen, there is a sustained stimulation for the antibody formations. So we find a very high rise of antibody in case of the chronic infections. And these antibodies then binds with the antigens at joint locations, and this immune complex formation excites the complement fixation, and this complement fixation leads to the activation of the complements, inflammation of the joints by the cytokines and chemokines that is liberated near the synovial and the muscle tissues. That is the pathogenesis of the disease, at least in chronic conditions. And this is further attested by the synovial biopsies from the chronically infected humans that showed the chikungunya infected perivascular macrophages, large number of CD14 macrophages or monocytes, and activated CD56 and CD69 and NK cells around the perivascular areas of the affected joints. Clinical features, you note the bending patterns of the persons in the right lower part. The common symptoms, they say acute onset of fever with chills and with joint pain. Joint pain is so severe that they can leave the bed even, and it is symmetrical in both sides. 85% of the exposed become ill, and 15%, even 15% may remain asymptomatic. Very similar to dengue in this respect, except that chikungunya virus, there is no hemorrhagic or shock syndrome. Other symptoms are maculopapular rash, usually appears within first 3 days of the illness, associated with a headache, backache, myalgia, retroorbital pain not so pronounced, arthritis, GI symptoms, and severe malaise. There are 2 phases, acute and chronic. In the acute phase, generally last about 1 week, where we find the severe headache and malaise, and the chronic for months and years. And it shows the features similar to the rheumatoid arthritis with fatigue and depression. It is more likely in immunocompromised, elderly, neonates, and very young. Rarely it is fatal, less than 1%, but morbidity is very high, unlike the dengue, where the morbidity is low, but mortality is significant. This shows the arthritis in the lower limbs, and also the maculopapular rashes over the skin, and also the face. And this depicts the prevalence of the signs and symptoms. You note that fever and joint pain 100% cases, joint swelling at least 40% cases, rash at least 28% cases, back pain 41%, and it is associated with low prevalence of headache, shoulder pain, retroorbital pain, difficulty in walking, polyarthritis and vomiting. Clinical features in a nutshell, so it is a self-limiting illness characterized by sudden onset of fever, headache, fatigue, nausea, etc., which last about 1 to 10 days. However, arthritis may persist for months and years. This is a chronic arthritis pictures of some of these helpless patients. Often it is said that how we can differentiate between chikungunya, dengue and Zika. So this is a comparative chart. We find the fever is more pronounced in chikungunya and dengue. In Zika it is a low-grade fever. Rash is more pronounced in Zika, but less so in chikungunya and dengue. Myalgia is more prominent in dengue, but less in chikungunya and Zika. Arthralgia, this is more prominent in chikungunya, less in dengue or Zika. Retroorbital pain, more prominent in dengue, lesser in chikungunya and Zika. Conjunctivitis, it is not found in case of dengue, but conjunctivitis, redness of the eyes, is chikungunya and dengue is more pronounced. Lymphadenopathy is found in chikungunya and dengue, and it is usually not found or found in a very low percentage in Zika. Hepatomegaly, this is very, very pronounced in chikungunya. I said in the onset of this lecture that the virus has got a tissue tropism more pronounced towards the liver and muscles and joint tissues. So the comparative clinical picture of chikungunya, dengue and Zika. So lymphadenopathy is more pronounced in chikungunya and dengue, but that is not very, very pronounced. But hepatomegaly is very pronounced in case of the chikungunya, not found in dengue and Zika. Here hepatomegaly is not found clinically. Hemorrhage is not found in chikungunya and Zika, which is more pronounced in dengue. So in a nutshell, we can say that if you find hepatomegaly, go for chikungunya. If you find hemorrhage, it goes in favor of the dengue. And if you don't find either hepatomegaly or hemorrhage, then it goes in favor of the Zika. Natural history of the disease is depicted here. You note that day 1 of the bite followed by the 4 days, about 4 days incubation period. In the incubation period, the patient viral load gradually increases, and when it reaches to a critical level, then fever starts or the signs and symptoms starts. And it may persist for about the fever, or it may persist 7 to 10 days. And usually in the initial part, that is in the day 0 to days 4, 5, 6, we can detect the viral RNA in the systemic circulation, and clinical manifestations are usually noted in up to the 7. But the IgM antibody, they appears at about the 5 days in a very small quantity, but 6 to 7 days, yes, it is a significant amount that can be detected in the peripheral blood, and IgG takes about the 14 days, or in the second week, the IgG antibody appears in the blood. So for strategy, in the first week, in the first few days of the illness, from 0 to about 4 days, 3 to 4 days, viral RNA detection by RT-PCR is to be done, or you have to do the virus culture, which is very difficult. And you can detect the serological evidence of the disease at the end of the first week, which is about the 5th day of illness, and after the second week, you can detect the IgG antibody also. So this depicts the chart that the 2 to 4 days incubation period, gradually the viral load increases. So in the first 3, 4, 5 days viral load, you can detect the virus by RT-PCR. But subsequently, beyond 5 days, yes, you have got another tool, that is the IgM antibody, and subsequently IgG antibody appears. And by the end of the 7 days, usually the sign symptoms subsides, but it may recur, it may recur time to time in the subsequent months in some individuals where the lingering polyarthritis is the hallmark of the disease or complications of the chikungunya virus infection. So, as regard the laboratory diagnosis, serum is collected. If it is 6 days, less than 6 days of illness, virus isolation may be done, or you can go for qRT-PCR, and this RT-PCR may be positive or negative. If it is positive, report. If it is negative, then you go for MAC ELISA after 5th or 6th day of the illness. If it is positive, print and report. If it is negative, you repeat it after few days, after 7 days, and then surely it will be positive. One point is very important, that there is an antigenic sharing between the dengue, chikungunya, Zika and yellow fever viruses. So, if a patient already suffered from dengue illness, the chikungunya might be positive, serological evidence of chikungunya might be positive in earlier, or there may be the cross reaction between the dengue, chikungunya, Zika and yellow fever. But mind that even if it is a cross reacting antibody, because of the epitopic sharing of the antigens, it does not impart the protection against the other. So, dengue infection surely produce antibody which cross reacts with the chikungunya, but it cannot neutralize it. In vitro serological test shows some cross positivity because of the antigenic sharing. With this, we conclude the chikungunya. Now, KFD or Kayasunior forest disease. Kayasunior forest disease, we take up these following issues. It is present in a geographical distribution. It is started with the Shimoga district of Karnataka, but now it has spread to the adjoining Tamil Nadu, Nilgiri districts, some other districts of the Karnataka, as well as the Wayanad and Malappuram districts of the Kerala. The transmitting agent is a tick, heart tick, which name of which is Haemophilus spinigera, and the vector, that is the vector, and the vertebrate host in the symbiotic cycle is usually monkey, usually langur, or it might be bonnet monkey present in the Malabar Hills forests. The usual season is KFD season is between January to May, where the ticks were very hungry and they feed on the vertebrates, and in this way they transmit the disease. Since this is an arbovirus, it maintains in the tick either by the biting of the individuals who are suffering from the disease, or it might be transmitted through the transovarian transmission. Here in the picture, the transovarian transmission is shown on the left side. So, that is the cycle of the tick and the transmission of the virus. Apart from the monkey, which is present in the sylvatic cycle, which is the reservoir, we find when the virus is transmitted to the peridomestic area, we find the birds and cattle and other domestic animals also become the host or the amplifier host for the virus. There are several epidemics. It started from 1957, and every year there are monkeys are killed by this virus in these forest areas, and human cases are secondary to the monkey falls, and every year at least 50 to 500 cases are being reported still now in those areas. About the virus, it is the Arbovirus, surely class Arbovirus. Its family is Flaviviridae and the genus is KFD. It is a spherical icosahedral virus and it is enveloped. It has a positive sense single-stranded RNA, as we find in case of the chikungunya. The virus is highly contagious and there are reports that lab workers are affected by it, and that's why it is recommended that the virus should be dealt with in a BSL-4 type of laboratory for the security. Clinical feature onset is very sudden with fever, chill, frontal headache, photophobia, myalgia, as similar to the chikungunya or Zika or dengue virus. Fever is a continued type, maybe up to the 2 weeks or more, which is unlikely in other chikungunya or Zika and dengue virus. So it is a prolonged illness and continued type of illness, as is found in case of the enteric fever. We find the rash, papulovesicular rash over the palate or inside the mouth, bleeding, gum bleeding, epistaxis, hemoptysis, melena, fresh bleeding in the stool. These are common, and this is responsible for the fatality of the cases. Convalescent usually delayed maybe 4 weeks, and the relapse often observed after 1 to 2 weeks after the first febrile period, and it lasts for 2 to 12 days. Symptoms are similar to the first phase, and additional symptoms after prolonged relapse or repeated relapse, it might be mental disturbances, giddiness, and reflex abnormality. In the lab finding, it is leukopenia and associated thrombocytopenia is not uncommon. Death is due to massive hemorrhage in the alveoli and GI tract. And there is no vaccine about it. And disease is demonstrated, disease is confirmed by its clinical features only. And we don't have any kits. Only in the certain centers there are facilities for demonstration of the antibodies against it. Then Crimean Congo hemorrhagic fever, the third one that is going to take this class. The picture shows it is transmitted by the tick, size of the tick. You can imagine when it is compared to a finger. And Crimean Congo hemorrhagic fever is the emerging viral disease in India, and that's why it is commonly asked in the examination, and sometimes it is given as a short note too. So Crimean Congo hemorrhagic fever, it affects the domestic and peri-domestic areas in the cattle population and also human being. And India, the cases were reported. First case was reported in 2010 in Gujarat. He was admitted in December 27th, and the case died on the 3rd of January. And the second case was admitted on the 6th, and the second case also died on the 13th of the January. And the case B, husband of the case B, was admitted on the 16th, and he was cured and discharged on the later part of the month. And at the end of the January again E case was admitted. So the disease sporadically occurred in a certain locality of the Gujarat area as a first evidence of the disease. Nowadays, altogether a large number of cases is being reported in different districts of the Gujarat as well as some adjoining areas of the Rajasthan too. The virus is circular, icosahedral, enveloped virus, and it is an arbovirus, and it belongs to the Bunia viridae family, and its virus is called the nairovirus. Its nucleic acid is segmented. There are 2 segments of the RNA we find, and just like other arboviruses, it shows glycoprotein peplomers also. So it is class arbovirus, Bunia viridae family, nairovirus sphaerica, envelope, and it has a negative sense RNA, segmented 2 copies. It is highly contagious, and lab workers might be affected. So it is also to be processed in the BSL-4 laboratories. And you will find in analysis of the Crimean Congo hemorrhagic fever, And in India, there is a list of the cases. You find that in Amreli district 11, Aravalli 3, Rajkot 2, Kutch 2. So it is different districts it has been spread. But the disease is not restricted to the Africa, Congo region and India only. You find that large areas of the world is affected by the Crimean Congo hemorrhagic fever. Vector is Ixodes tick, genus Hyalomma family. Hyalomma. Here is an amplifying host. Amplifying host is the cattle, goats, sheep and hares. And animal to man may be transmitted by the vectors, and the man to man again transmitted by the contact to the blood and body fluids. And improper sterilization of the medical equipment, reusable of injections, syringes and needles, and contamination of the medical supplies are also responsible for man-to-man transfers. Persons at risks are those who are animal handlers, slaughterhouse workers, as well as the healthcare workers who are treating these cases. Clinical features: very sudden onset of fever with petechi and jaundice are common, but we find associated headache, backache, joint pain, stomach pain, vomiting, red eye, flushed face, red throat. These are also common. And in severe cases, changes in the mood and sensory perceptions are also noted. Disease within 4 to 14 days of the disease, we find bruising, severe bruising and epistaxis bleeding at injection sites might be found. Case fatality rate varies between 9 to 50%. Diagnosis in the acute phase: antigen detection by antigen capture ELISA or RT-PCR, which can detect the viral RNA, and virus isolation, which is very difficult and done only in the reference laboratories. And in the second week onwards, antibody detections, initially IgM, MAC ELISA, and later on IgG also may be detected by the ELISA. And prevention which proper clothing, insect repellent, and vaccine is required. An inactivated mouse brain derived vaccine against CCHF have been developed and is used in a small case in Eastern Europe, and further research is needed before the vaccine could be introduced in India.